Pardon, sir?
How many people have joined the meeting?
I don't see it, sir, but our head office people will tell, sir. They'll tell us.
That's okay then. No, not a problem.
Yes, sir.
So we are live. We are live.
Yeah, like. So, good evening, everyone. And on behalf of Hetero Healthcare, I welcome you all for this webinar. Hetero prides itself for being one of the few pharmaceutical organizations that thrive on a robust research and development program. 21 years of expertise in pharmaceutical, 25 plus state-of-art manufacturing facilities, presence in more than 120 countries, 15,000 plus employees across globe, 200 plus product in portfolio, largest privately held pharmaceutical company in India. Hetero Research Foundation started as early as in the year 1995, spearheaded by more than 500 top-notch scientists. Excellence in developing generics, difficult to make and complex APIs, novel drug delivery system, new chemical entities, and biosimilars. Hetero Healthcare is one of the world leaders in developing and manufacturing wide range of brands in various therapy segments, including gastroenterology and hepatology. More than 3 decades of experience in manufacturing and marketing pharmaceuticals. Hetero Healthcare has also been in forefront for providing drugs for COVID-19 pandemic, such as Coiffor injection, that is remdesivir, and Favir tablets, that is Favipiravir. Hetero Gastrocare is committed towards creating awareness about hepatitis B and C, along with products like Heptivite, providing access to high-quality medicines at affordable rates and enriching lives of patients for better well-being. Adding to the portfolio, we are pleased to introduce Midohep, a brand of midodrine hydrochloride, a vasoconstrictor being widely used in orthostatic hypotension and various secondary hypertensive disorders. It has been recently shown to have a significant improvement in cirrhotic patients with ascites. Also, we are pleased to introduce Inmeth suppositories, a brand of Indomethacin to be administered rectally. Pancreatitis is a common and severe complication of ERCP. Various studies have shown efficacy of rectally administered Indomethacin in preventing post-ERCP pancreatitis. For further detailed discussion on this topic in our today's webinar, Management of Refractory Ascites and Rectal Indomethacin in ERCP to Prevent PEP, I would like to introduce a moderator and speakers. A moderator, we are pleased to have Dr. Nagarjuna Yerlagada sir, MDDM PGI, Chief Gastroenterologist, Hepatologist, and Therapeutic Endoscopist, Medical Director, Sunshine Hospitals, Gachibowli. And speaker we have Dr. K. Somashekar Rao sir, MD General Medicine, DM Gastro, Consultant Gastroenterologist, Hepatologist, and Therapeutic Endoscopist, Apollo Hospitals, Jubilee Hills, Hyderabad. And we have speaker Dr. Naveen Polavaru sir, MRCP UK, FRCP Gastro, CCT Gastro, Liver Transplant Fellowship, Hepatologist, Transplant Hepatologist, Apollo Hospitals, Jubilee Hills, Hyderabad. And it gives me immense pleasure to have a allied faculty in today's webinar, and very overwhelmed and very happy, delighted to have our 3 eminent guests here. I would like to hand over the session to our moderator, Dr. Nagarjuna sir, to take it further and follow the proceedings of the program. Dr. Nagarjuna sir, please.
Thank you, Atik. I think someone has put me off on the video. Maybe my gray hair is putting me off. Yeah. Okay. Am I visible now?
Now you can see, sir. Please.
Oh, good. Thank you. Okay. So thanks a lot, Adi, for organizing this program, Hetero Group and all your team. And today I have two very nice, good, close friends and neighbors, and who are the speakers today. I'm happy that both of them are there. One is Arson Sekhar, the other one is Naveen. Today we have 2 interesting topics. It is nice that 2 different topics were picked up, which are helpful in the day-to-day practice. Particularly, both the topics are mostly for the senior physicians and also for the gastroenterologists. Having said that, a lot of us see these patients of both refractory ascites and post-ERCP pancreatitis in our clinical practice. For the refractory ascites, yes, a lot of physicians they see these patients in day-to-day practice. So with this, I mean, I can tell you a little more about the topic, but anyhow, they came prepared. So I think it's fair for me to invite them for today's talk. As the name suggests, it's difficult to manage. That is a refractory ascites. So the first speaker is Somashekar, and he'll be talking to us about the refractory ascites. Somsekhar?
No. Post-ERCP pancreatitis.
Okay. I'm sorry. I took the liberty of mismatching both the things. So Somsekhar is going to speak to us about the indomethacin in ERCP to prevent post-ERCP pancreatitis. In case of ERCP, all of us know when you enter the pancreatic duct, there's a possibility some of the patients may unknowingly get a pancreatitis. Sometimes it will be severe, but in young females. So to prevent that, some new developments have come. One of the important development is a small drug, like Indomethacin, which is making a lot of wonders. And this topic will be dealt by Dr. Somsekhar. I'm sorry, Somsekhar, about this. On to you now. Thank you. Somsekhar, yeah, you're there.
Good evening, everybody. Atik, can you start the slides, please? Yeah.
Yeah, all the slides.
Can you hear me, sir?
Yes, loud and clear.
Yeah. Good evening, everybody. Today's topic is actually about post-ERCP pancreatitis and prevention of post-ERCP pancreatitis. And we will be talking about the role of rectal indomethacin in preventing post-ERCP pancreatitis and acute pancreatitis.
Somsekhar?
Sir.
So, small this one was, or I mean, you want the video to be off, or is it okay for you to have the video? I cannot see your face.
I thought the slides will be there.
That is fine. Your choice.
Yeah.
Yes.
So next slide, Atik. So initially we will talk about acute pancreatitis and then we'll go to the actual topic. Acute pancreatitis is an inflammatory condition of pancreas which is caused by autodigestion of the glands by its own digestive enzymes, and it can lead to functional impairment and morphological changes of pancreas. The condition may recur intermittently, giving rise to chronic pancreatitis. Severe acute pancreatitis may occur in about 25% of cases with acute pancreatitis. And incidence of acute pancreatitis is relatively higher in USA, Finland, and Scotland. In India, the prevalence of acute pancreatitis is, if you can see the range here, mean age is around 45.4, ranging between 26 to 57. And if you see the age ranges, 10 to 30 years, 13% of these people are affected with acute pancreatitis. And highest number is seen in the age group of 31 to 50. It's around 56%. And in above 50%, above 50 years of age, it is around 30%. Etiology and pathogenesis of acute pancreatitis. And these are all the causes of acute pancreatitis. Most common: gallstones, alcohol, malignancy, and mucinous tumors. And alcohol can cause retinal cell injury, and other causes are trauma, ischemia, viruses, and hereditary pancreatitis, hypercalcemia are other causes of acute pancreatitis. Post-ERCP pancreatitis is also seen in many of these cases. Pancreas divisum, sphincterophore dysfunction. Few drugs like corticosteroids, azathioprine, and thiazides can cause pancreatitis. Hypertriglyceridemia and autoimmune pancreatitis. These are all the causes of acute pancreatitis. And when we are talking about alcohol plays a special role here. It triggers acute pancreatitis via multiple mechanisms. That's what we have been seeing here. Alcohol can cause ductal obstruction. Alcohol can cause acinar cell injury, and it can cause defective intracellular transport. So the next slide, please. Diagnostic approach. The diagnosis of acute pancreatitis must be considered in any patient presenting with abdominal pain. History and examination can be indicative of acute pancreatitis. However, 2 out of the following 3 criteria should be met for diagnosis. A typical history: epigastric pain radiating to the back associated with vomiting or nausea. Elevated serum amylase and lipase it should be at least 3 times upper limit of normal, and imaging findings either CT, MRI, or sometimes ultrasound, which is consistent with acute pancreatitis. Any of the two criteria should be fulfilled to diagnose acute pancreatitis. Classification of disease severity. Whenever you see a patient with acute pancreatitis, disease severity plays a very important role, because most importantly, mild acute pancreatitis, there may be no local or systemic complications or organ failure. Moderately severe acute pancreatitis, local or systemic complications, transient organ failure, or both can be seen in less than 48 hours. In severe acute pancreatitis, local or systemic complications and persistent single or multiple organ failure is most commonly seen. And when you want to define what is mild acute pancreatitis, there is no pancreatic or peripancreatic necrosis and there is no organ failure. In moderate pancreatitis, pancreas can be sterile pancreatic or peripancreatic necrosis, transient organ failure for less than 48 hours, or both. In moderately severe acute pancreatitis, infected pancreatic or peripancreatic necrosis or persistent organ damage which is lasting for more than 48 hours. In severe acute pancreatitis, it is infected pancreatic or peripancreatic necrosis and persistent organ failure which is more than 48 hours. Next slide, please. So local complications are defined according to the revised Atlanta criteria. So you can see in the pictures here, the first one is representing acute peripancreatic fluid collection. There is interstitial edematous pancreatitis less than 4 weeks. The B, if you see the B picture here, acute necrotic collections are seen, necrotizing pancreatitis at less than 4 weeks. In the C, you are seeing a pancreatic pseudocyst and acute interstitial pancreatitis, which is more than 4 weeks. The fourth, the D, you are seeing a wall of necrosis, a patient with necrotizing pancreatitis at more than 4 weeks. So these are all the different presentations what we see in different time intervals after the onset of acute pancreatitis. Local complications of acute pancreatitis. So interstitial edematous pancreatitis, there will be acute inflammation of parenchyma or peripancreatic tissues. Radiologically, there is enhancement of pancreatic parenchyma with no signs of necrosis. In necrotizing pancreatitis, necrosis encompassing pancreatic parenchyma or pancreatic tissues is noted. Radiologically, we see a acute necrotic collection lacking a definable wall containing variable amounts of fluid, or there can be wall of necrosis containing a well-defined encapsulated collection. Acute peripancreatic fluid collections, there is a homogeneous collection of fluids with no distinct inflammatory walls outside pancreas containing minimal or no necrosis. Within the first 4 weeks after the onset of interstitial edema, this is the most important. It should be less than 4 weeks. Then only we call it as acute peripancreatic fluid collection. And radiologically, you see a homogeneous collection with fluid which is confined by normal facial planes. Pancreatic pseudocyst. These are the collections of fluids that contain distinct inflammatory walls outside the pancreas containing minimal to no necrosis. Radiologically, you see a clear homogeneous fluid with well-defined borders that is encapsulated. And what is acute necrotic collection? These are the collections of both fluids and necrosis associated with necrotizing pancreatitis. Radiologically, you see a intrapancreatic or extrapancreatic heterogeneous non-liquid density of varying degrees with no definite wall. Wall of necrosis. This is an encapsulated collection of pancreatic or peripancreatic necrosis that has formed a distinct inflammatory wall. Radiologically, you see a heterogeneous liquid or a non-liquid density with varying loculations. The structure has a well-demarcated wall that is entirely encapsulated. You may see complications like thrombosis, pseudoaneurysm, and abdominal compartment syndromes. These are all problems of peripancreatic this thing, and there can be thrombosis of pancreatic venous circulation, including splenic vein, portal vein, or superior mesenteric veins. Pseudoaneurysm can be seen. It can be seen in any of these veins most of the time, and abdominal compartment syndrome. This is because of the tissue edema that is secondary to aggressive fluid resuscitation, peripancreatic inflammation, and ascites. Next slide, please. So, ERCP. What is ERCP? Every one of us know here. It's a complicated, you can say, therapeutic modality. Most of the time, when we are talking about acute pancreatitis and ERCP, biliary pancreatitis is an indication for ERCP, and normally, other than acute pancreatitis, if you are talking about ERCP procedure, it is clinically the most common and specialized procedure used for diagnosis and treatment of pancreatic and biliary system disorders. Most common indication would be a common bile duct stone, and if this common bile duct stone is causing acute pancreatitis, we may have to do ERCP and remove the stone. And there are many other indications for ERCP where post ERCP pancreatitis can happen. Next slide, please. ERCP is performed when bile or pancreatic ducts have become narrowed or blocked. It can be because of gallstones from that form in gallbladder and become stuck in common bile duct. It can be because of some infections. In cases of acute or chronic pancreatitis, sometimes we may have to do an ERCP if there is a distal CBD stricture or if there is a obstruction to the pancreatic duct. Trauma or surgical complications in bile duct or pancreatic duct problems. Pancreatic pseudocyst, sometimes if we have to drain through the pancreatic duct, we do an ERCP. And tumors or cancers of bile ducts or pancreas, we may have to do an ERCP sometimes to relieve the obstruction of the bile duct. These are all the indications. Risks related to ERCP. So, pancreatitis is the first most common complication what we encounter. Cholangitis, perforation of the duodenum, hemorrhage, cholecystitis sometimes, cardiopulmonary depression during the procedure, asymptomatic hyperamylagemia we see in most of the cases, aspiration, hypoxia. These can be seen as most of the time when we do the procedure under sedation, bleeding, sepsis, and adverse medication reactions in view of when we do the procedure under sedation. These are all the risks which are related to ERCP, but most of them are less than 5%. So only important thing which we should be more careful is preventing post ERCP pancreatitis. Rest of the complications, most of the time, hemorrhage, it is always post sphincterotomy. It's always post sphincterotomy, so it can be controlled. Cardiopulmonary depression and all those things can be definitely, those things can be prevented by taking adequate precautions before the procedure. So most of it we are talking about pancreatitis, and post ERCP pancreatitis can be prevented, and we will see how and what we can do in post ERCP pancreatitis. Next slide, please. So when we are talking about risk factors, patient-related risk factors are also very, very important in considering post ERCP pancreatitis. Post risk factors are mostly related to definite risk factors would be younger age, female gender, suspected sphincter of Oddi dysfunction, patient, if he is having, he or she is having history of recurrent pancreatitis, absence of chronic pancreatitis, and a history of previous post-ERCP pancreatitis is a definite risk for ERCP related complications. Possible risk factors: absence of a CBD stone, normal serum bilirubin, and periampullary diverticulum. These are possible risk factors for post-ERCP pancreatitis. And no risk is seen in when we see a small caliber diameter of CBD, pancreas disease, allergy to contrast medium. Next slide, please. Post-ERCP pancreatitis. First, we will talk about what is this post-ERCP pancreatitis. It's the most common complication of ERCP, and it is a crucial factor in morbidity and mortality. Chemical, mechanical, enzymatic, hydrostatic, and thermal causes are considered as the pathophysiology of post-ERCP pancreatitis. Development of post-ERCP pancreatitis is thought to be based on a pro-inflammatory cascade, which is caused by pancreatic SNR cell injury that induces to systemic cytokine release. The economic and social impacts of post-ERCP pancreatitis have been reported to be substantial. Predicting pancreatitis after ERCP can be very difficult. Next slide, please. Incidence of post-ERCP pancreatitis. A total of 959 patients were enrolled in a study where we are comparing Indian centers and US centers here. Difficult cannulation, most common procedural risk factor. It was seen in 85% of Indian centers, 76% of US centers. Failed cannulation, similarly, it's 14% is seen in Indian centers and 14% is seen in US centers. Pancreatic sphincterotomy was a risk factor in just 0.7% in Indian centers, and it was 18% in US centers. Pre-cut sphincterotomy was the cause of post-ERCP pancreatitis in 22% of Indian centers. It was seen only in 4% of US centers. More than 2 pancreatic duct injections. This was the reason for post-ERCP pancreatitis in 0.8% of Indian centers and around 18% in US centers. Incidence of post-ERCP pancreatitis was seen in 6.3% of Indian centers and around 12% of all the ERCPs in US centers. So patients who had post-ERCP pancreatitis, duration of hospitalization was around 2.2 plus or minus 3.55 days at Indian centers, and it was around 4.07 plus or minus 7.42 days in US centers. Okay. Next slide, please. Now, what are the standard consensus and definitions of post-ERCP pancreatitis? Standard definition proposed by Cotton layman is as follows. Pancreatitis after ERCP is a clinical illness with typical pain in the epigastric region radiating to the back, associated with at least a 3-fold increase in serum amylase at 24 hours, with symptoms impressive enough to require admission to hospital for treatment. So we were talking about a term called asymptomatic hyperamylasemia. So we don't need to do a serum amylase in every patient. Only when there are typical symptoms suspecting acute pancreatitis, we do serum amylase and lipase in these patients after an ERCP. So those patients are only considered. This is the standard definition for post-ERCP pancreatitis. Atlanta criteria based definition of post-ERCP pancreatitis is the diagnosis of acute pancreatitis requires 2 of the following 3 features. Abdominal pain consistent with acute pancreatitis, which is acute in onset of a persistent severe epigastric, often radiating to the back. Serum lipase activity at least 3 times greater than upper limit of normal. And characteristic findings of acute pancreatitis on contrast enhanced CT and less commonly MRI or an ultrasound. So this is the criteria at least 24 hours after an ERCP procedure. If you have these symptoms, we call it as post-ERCP pancreatitis. Next slide, please. Suppositories. Suppository is a medicated solid dosage form which is intended for insertion into body orifices where they may systemic effects. The medication is incorporated into oil-based which melts at body temperature or into water-soluble or miscible base which further dissolves in the mucous secretions. Advantages of PEG base. These are chemically stable, inert, non-irritant, do not allow bacterial growth. Physical properties changes according to the molecular weight. It provides prolonged action, and suppositories are clean and smooth in appearance. Next slide, please. So we'll talk about rectal blood circulation here because we will know how it is going to help. Middle and inferior hemorrhoidal veins drain direct stomach enzymes of stomach and fast metabolism in liver. Suppose if it's too high, it's absorbed upper hemorrhoidal vein, which drains in the portal vein, flowing to the liver. So these are the advantages why we use a suppository. Next slide, please. Next slide, please. Okay, we are talking about indomethacin. Indomethacin is a non-steroidal anti-inflammatory agent with analgesic properties. When given as single dose, it is inexpensive, easily administered, and favorable risk profile. It is an attractive option in prevention of post-ERCP pancreatitis. So I don't want to go into the details. Most of us know about indomethacin, but we are talking here the advantages of rectal indomethacin in post-ERCP pancreatitis here. So there are advantages when we compare to an NSAID in indomethacin. So we'll go to the next slide, please. So we'll talk about the advantages of rectal indomethacin versus diclofenac. It's a comparative study of indomethacin, diclofenac, or naproxen for prevention of post-ERCP pancreatitis. It's a double-blind randomized study. Patients received a single rectal dose of one of the three drugs 30 minutes before undergoing ERCP. Diclofenac 100 mg, indomethacin 100 mg, or naproxen 500 mg. The primary outcome measured was the development of pancreatitis, and diclofenac and indomethacin patient groups had a lower incidence of post-ERCP pancreatitis than naproxen group. Rectal indomethacin or diclofenac is recommended for prevention of post-ERCP pancreatitis. Next slide, please. This study shows that rectal indomethacin prevents moderate to severe post-ERCP pancreatitis and death and should be used before the procedure. 8 trials were published between 2007 and 2016 with a number patients were 3,324. All these trials used relatively similar criteria to define post-ERCP pancreatitis, and all included studies 100 mg of rectal indomethacin. When you see in the detail, the number of post-ERCP pancreatitis were less, and multiple. It was done in multiple countries, and most of the rectal indomethacin, wherever they used, the post-ERCP pancreatitis incidence was very, very less. Next slide, please. Oh. Next slide, please. The pooled proportion estimates of post-ERCP pancreatitis, like it was when they were using rectal mitomethacin, it was 5.6 with and it was 8.8 in placebo. Rate of post-ERCP pancreatitis was significantly lower with rectal indomethacin as compared to placebo, and it was significant statistically. Next slide. Meta-analysis suggests that rectal indomethacin is effective in preventing post-ERCP pancreatitis. It prevents the post-ERCP pancreatitis, including high-risk patients, effective in those with sphincterophore dyskinesia, significantly decreases the rate of moderate to severe post-ERCP pancreatitis and death in all patients. Rectal indomethacin should be given to all patients without a contraindication prior to ERCP. This is the recommendation actually. Rectal indomethacin is protective against pancreatitis after ERCP. This was a systemic review and meta-analysis where a total of 6,094 patients undergoing ERCP with 459 patients presenting with post-ERCP pancreatitis. 10 randomized control trials have evaluated with 100 mg rectal indomethacin suppository. Prevention of post-ERCP pancreatitis with rectal indomethacin was seen in 4.83 to 13.66% patients and the risk ratio of 0.63. Rectal indomethacin significantly decreased post-ERCP pancreatitis among high or average risk population undergoing ERCP. So rectal indomethacin seemed to be an ideal and an appealing post-ERCP pancreatic prevention of post-ERCP pancreatic option, considering its ease of admission, cost effectiveness, and safety. Next slide. Rectal indomethacin to reduce post-ERCP in low-risk patients. This study evaluated role of rectal indomethacin in low-risk patients. A retrospective cohort study with available papers starting November 2012. This rectal indomethacin reduced post-ERCP pancreatitis in consecutive as well as low-risk patients. So this is a suggestion that the rectal indomethacin should be administered in consecutive patients unless contraindicated. Larger prospective studies are needed to confirm these results, but according to this retrospective cohort study, we suggest rectal indomethacin to every patient 30 minutes before ERCP, even low risk patients. So maybe larger studies needs to be done to confirm all these things, but this study suggests for every patient. Next slide. What is the European Society of Gastrointestinal Endoscopy guidelines? Post-ERCP pancreatitis, non-steroidal anti-inflammatory drugs are recommended. ESGE recommends routine rectal administration of 100 mg of diclofenac or indomethacin immediately before ERCP in all patients without contraindications to NSAIDs. Strong recommendation and moderate quality evidence. Next slide, please. Algorithm for prophylaxis against post-ERCP pancreatitis. So if you see from the, any contraindication to NSAIDs, please don't give. Give rectal indomethacin or diclofenac less than, if there is no contraindication, you can give rectal indomethacin or diclofenac 100 mg. No further intervention is required. Standard cannulation and difficult cannulation without easy pancreatic stenting, then there is no need of further intervention. Difficult cannulation with easy pancreatic stenting, pancreatic stent should be placed. When there is any contraindication to high volume hydration, if there is no contraindication, then please start Ringer lactate 3 ml per kg per hour and continue hydration. Pancreatic, if the pancreatic stent is placed, then we are fine. Hydration can be continued. If no pancreatic stent is placed, 20 ml per kg bolus after ERCP and 3 ml per kg per hour for 8 hours. If there is any contraindication for previously, then is any contraindication for high volume hydration, then consider sublingual glycerol nitrate 5 mg. Consider pancreatic stenting. This is the algorithm for prevention of prophylaxis of post ERCP pancreatic. Next slide, please. Okay. So we will talk about the takeaway pointers here. Rectal indomethacin is effective in preventing post ERCP pancreatitis in high and moderate risk patients. It significantly decreases the rate of moderate to severe post ERCP pancreatitis and death in all patients. It provided strong evidence for current guidelines in clinical practice. Rectal indomethacin is effective and it prevents post ERCP pancreatitis in patients with even low risk. Rectal indomethacin should be given to all patients without a contraindication prior to the ERCP. It is an ideal and appealing post ERCP pancreatitis preventing option because of its ease of administration, cost effectiveness, and safety. Thank you for your patience listening. Thank you, sir. I will, if there are any questions, I will be ready to answer.
Thank you so much, Secretary. It was a very nice lecture. Very good. And we covered all the points you covered. So I doubt if anyone has any doubts, but still it's open for discussion. So I think both topics being separate topics, maybe for a few minutes we'll take up the questions for your session, and then we'll go to the Naveen's refractory ascites. So
Yes, sir. We have some questions.
Yeah.
I'm posting on Zoom.
Yes, I think a query from Prabhakar. So, which definition should we use for post-ERCP pancreatitis? Is the one by Cotton et al., which mentions that serum amylase should be measured 24 hours after the procedure, and the patient requires hospitalization, or the normal definition. So,
no, ideally, unless you have a pain abdomen, typical of pancreatitis, you don't do any amylase or lipase in after ERCP. So asymptomatic hyperamylasemia can be again mistaken as post ERCP pancreatitis. So ideally, pain, typical pain, and elevated serum amylase and lipase more than 3 times upper limit normal.
Okay. So what's your point on the, is it amylase should be checked soon after the pain or 24 hours after the pain? Because after ERCP, there can be some pain. There can be pancreatitis or can be other pain also, maybe distension or what it could be. So what do you take on that?
Immediately after ERCP, sir, it should wait at least 24 hours.
Okay. So that is one. And the second one is, after how many hours of the procedure should amylase and lipase be checked to diagnose post-ERCP pancreatitis in patients who complain of abdominal pain? I think this is already answered. Can't midodrine and diuretics be combined? I think this must be for the next topic. And the fourth question is, should prophylactic PD stenting be done in only high-risk patients or in all average risk patients as well, as demonstrated by a recent study in AMS? So what he was trying to say is, earlier, any high-risk patient, like young females with suspected sphincter aortic dysfunction, we used to put the pancreatic stent. So the question is, should you do it for all the cases of ERCPs? Wherever you do ERCP procedure, maybe is it necessary to put a PD stent for everybody? Your take.
No, sir, I don't think it should be done at all. Unless you have a suspicion, if you have suspicion that these patients, if you have cannulated the PD more than 2 times, or if you are seeing a large stone from the PBD when we are extracting, we will have a clear-cut features that suspecting this patient is going to develop, then only we put a PD stent. I don't think it should be done for everyone.
I completely agree with you, Somsekhar. I don't think there's no role for a unnecessary stenting for all the patients, particularly the average risk and low risk. Well, the next last question looks like is from Dr. Raj, from Rajan. Doctor, there might be chance patient may develop pain after release to home after ERCP. In this case, can we prescribe indomethacin to administer rectally at home? If yes, then what would be the dosage and how long it should be? The point is, I think the point is clear. Indomethacin has to be given before the procedure, right?
Yeah.
So
ideally, it should be given before the procedure, sir. But sometimes we can post procedure also.
Okay.
The side effects is actually very, very low. Even after post ERCP, when we have a solution, we can use indomethacin suppository.
Yeah, my opinion is
ideally we have to give it before the procedure.
Yes. So my opinion is before the procedure, it works to prevent the pancreatitis. Suppose if you use it very late after the procedure, it works more like a painkiller rather than a prevention of pancreatitis. This is my opinion.
Agreed, sir.
Yes. And another query, why indomethacin works for prophylaxis when administered rectally and not when administered orally or IM? You want to put any comment on that? Why only rectal?
We are actually trying to decrease the it can be effective IM or IP also, but indomethacin rectally has very, very less side effect profile. So these are all the studies why they were done rectal induced because rectal suppositories because of the less side effect profile.
So continues for the same thing. Can we use this indomethacin for all the patients of acute pancreatitis, irrespective of the etiology? Why only ERCP? Even for the gastropancreatitis, alcoholic pancreatitis, or any acute pancreatitis of any nature, can we just give a shot of indomethacin rectally?
Rectally. Maybe we can try, sir, because of the less side effect profile. Maybe we can try and I mean at least if we can give rectal indomethacin early, we may prevent the severity. That we can do a study also, sir. Actually, we can't say it right away like this.
I know.
But maybe someone we have seen in mild or moderate pancreatitis, maybe rectal indomethacin, we can do a study and see if it is preventing the further deterioration or organ failure.
Okay. Thank you so much, Sekhar. I think we're taking a lot of time, but the last point is, I don't think there's any data is available in this direction. But if the data is there, maybe we can think about it. But at this point of time, recommend is only for the post-ERC pancreatitis prevention only. This is useful. In other conditions, it works like just a painkiller, not more than that. Okay. I think, thank you very much, Samsek. I think I was a little partial to you. I've taken more time, and Naveen is waiting, I think. But there's a big switch. See, all these years, I thought Somsek is a liver guy and Naveen is a scope guy. But today, I think you reversed your roles and did a fantastic job. Let's see what Naveen is going to tell us. So, Dr. Please talk to us about the refractory ascites. Let's see the US guy.
Good evening, everyone. Sorry for joining late. I got stuck in the traffic. Let me just share my screen.
Welcome, Naveen sir. Welcome to the webinar.
Right.
Meanwhile, Naveen Polwarpu is a gastroenterologist, UK trained, and I know him as a very, I know more about his US skills. He also does liver work, but I like him and appreciate his US work more. Yeah.
Right. Can you all see my screen?
Yes.
Yeah. Yeah. So, yeah, as Dr. Nagarjun says, my interest is mainly predominantly US therapeutic endoscopy side of things, but I also have a lot of interest in liver transplant and hepatology side. So, In fact, that's what drives me, to be honest, in terms of the liver side of things. So I think
I believe you're trained in the liver also, I think.
Yeah.
In your program.
So well, in a way, I'm away from the luminal side. Okay. More of a hepatobiliary pancreatic side. That's what I got trained into. But of course, we see as a general, we see all of them. But the main interest is predominantly away from luminal hepatobiliary. Okay, so I won't spend much time, to be honest. I think we're already running late, so I'll quickly whiz. I've got a lot of slides, but I'll quickly whiz through most of the slides, especially the initial part, which is basically about the basics about the portal hypertension, cirrhosis, and stuff. So as we all know that when patients do develop chronic liver disease, it progresses, it's an irreversible process, and they reach the stage of compensated cirrhosis. And it's really only when they start developing the portal hypertension, what we call a clinically significant portal hypertension, where the progression of the disease or the cirrhosis starts significantly. And when they develop this decompensated liver disease, then the mortality rate significantly goes up, and we talk about the median survival rates of about 2 years once they reach the stage of decompensation. So I think really what has been said over the last few years is how to identify this clinically significant portal hypertension. So the definition, as it says, is if you have a HVPG gradient more than 10 millimeters of mercury, then that is called as a clinically significant. That's where you actually start seeing the symptoms. Because as you can see, if they're well compensated without developing any of these complications like hemorrhage, viral hemorrhage, ascites, or encephalopathy, or jaundice, their median survival rates are more than 12 years. But as they get into the stage of decompensation, when they develop any of these complications, your median survival rates dramatically come down to 2 years. So really, I think the lot of studies which actually showed is how to actually reduce this or break the cycle of progression from the clinically significant portal hypertension, how to reduce the CSPH. Okay, now we all know about the pathophysiology, what happens during the cirrhotic liver and why do they develop portal hypertension, why do they develop complications. So essentially there's increased hepatic resistance to the blood flow, which causes increased HVPG gradients, which is normally should be less than 5 millimeters. But as it grows up, the portal hypertension increases, then you start developing clinically significant portal hypertension, you start developing varices and the risk of variceal bleed. Along with it, there is a significant shunting of blood which happens, which results in splanchnic vasodilatation. This vasodilatation again causes more increased blood flow into the portal circulation, which increases the cardiac output, and it also reduces the effective systemic volumes in the systemic circulation. So therefore, you have an activation of the neurohumoral systems, renin-angiotensin system, and the sympathetic drive increases. As a result of this, you have increased sodium and water retention. You have a waterlogged system, and therefore you develop the complications like ascites. And because of this portal shunting which happens, you end up having encephalopathy. Of course, these are the three most important complications what we see, but there are other complications like portopulmonary hypertension, hepatopulmonary syndrome, and the hyponatremia and so on that we see. But these are the three main decompensations that we see. So the real target treatments that we actually look at in patients who have cirrhotic liver is when they have compensated cirrhosis. If they have mild portal hypertension, you really have to eliminate the etiology. For example, like in hepatitis B or C, or even in NASH-induced well-compensated cirrhosis, you try to target the insults or the etiology of these patients. But once they develop clinically significant portal hypertension, along with controlling the etiology, you also need to work on reducing the portal pressures. Therefore, you minimize the progression or towards the decompensated liver disease. Okay, so this is just a bit of background about the cirrhosis and the portal hypertension. Why do they develop portal hypertension and the complications? But out of all these, the most common complication that we see is the ascites, along with the variceal hemorrhage and the encephalopathy. Now, once the patient develops ascites, that's an important landmark in the natural history of their progression of the disease. And as I said, this is the most common complication that we see. And on an average, about 5 to 10% incidence that we see in patients with compensated cirrhosis who develop ascites on an year-on basis. Now, why is it important? Because, of course, it impacts the social life of these patients. They spend most of the time in the hospitalization. They won't be able to go back to their work. So, and they require a lot of treatments, which are costly treatments. So they have a social impact, the financial impact. Along with this, more importantly, they have it. As I said, it's a important landmark in the natural history in the disease progression, with a very poor survival rates. We talk about almost 30% survival rates, 5-year survival rates in these patients once they develop ascites. So I think it's very important to understand that, when patients or physicians see the ascites, that's an important landmark, and we need to work on preparing these patients for liver transplant, because we know that once they reach the stage of this decompensated liver disease with ascites, this is only going to be a progressive condition. Before they reach the stage of refractory ascites or develop other complications like hepatocellular carcinoma, I think it's important to drive them the message that once they develop ascites, it's important to work them towards the liver transplant. Now, ascites is divided into two things, two categories, or to make it easier, we call it as uncomplicated ascites or a refractory ascites. Now, I'll come back to refractory ascites in a bit, but let's just talk a little bit about the uncomplicated ascites or a straightforward ascites. Okay. Now, what do we call an uncomplicated ascites? It is an ascites which does not have any infection like an SBP. It is responsive to the treatment, i.e., it is not refractory, and there is no impaired renal function with the ascites. So it's basically simple ascites which responds well to the diuretics and do not have any renal impairment, and they respond well to the diuretics, as I said. Okay, and they don't have any infections. Okay, so it's important, as I said, in landmark in terms of the natural history of the disease progression. So once you see a patient with ascites, you need to make sure that this is only cirrhotic liver-related ascites. You need to make sure there are no other etiologies for the cirrhosis, for the ascites. So it's important to take the proper history, do a proper examination, get an abdominal ultrasound. In the abdominal ultrasound, you look at the liver architecture. And are there any nodules? Are there any HCC concerning nodules there? How is the portal vein looking? Is the diameter dilated? How is the flow looking like? Does the ascites have internal echoes to it, or does it look like a simple, straightforward ascites? How is the spleen looking like? Are there any evidence of portal hypertension? So you have to look for all these things to make sure that we make sure that the ascites is because of the cirrhosis. Because the reason I say that is, we have patients we are seeing increased number of NASH-related cirrhosis. So these patients with having diabetic nephropathy-related and hypertensive nephropathy-related progression of the disease, and not necessarily it's the cirrhosis which is causing, or NASH-related cirrhosis which is causing the ascites, but it is also the renal impairment with it which causes them to have ascites and NSR curve. So it's important to understand what is the etiology of the ascites. Is it the cirrhotic liver which is causing ascites, or are there any other conditions which is causing it? Of course, in this situation, high SAG ascites, measuring the SAG really helps us in understanding the nature of the ascites. So, so looking at the renal function, liver function, serum and urine electrolytes, analysis of the ascitic fluid. Of course, these patients are at risk of developing infections, including tuberculosis. So you've got to keep an open eye and put your net wide enough to understand that we kind of look for all the conditions or causes for the ascites. Now, ascites can be easily graded into 3 categories: mild, grade 1, grade 2, and grade 3. The grade 1 is the mild ascites, which is only detectable on the ultrasound scan. You should probably have at least 500 ml to detect on the ultrasound scan. Moderate ascites is when you have a symmetrical distribution of the abdomen, particularly around the flanks, so that it's a symmetrical distribution, having filling of the abdomen. And grade 3 is you have obviously gross ascites, tense ascites, which is quite obvious. This is what we see as a grade 3 ascites. Now, most of my talk from here, I actually extrapolated from the EASL guidelines, which is very helpful and very user-friendly. So I just took out the bullet points from this. We're happy to discuss in more detail if you do want to. But the uncomplicated ascites, for any patient who comes with ascites for the first time, you got to make sure that you tap the ascites, make sure that this is all cirrhotic liver related and there is no SBP, and you ruled out other conditions like tuberculosis. So you check for ADA, you check for any other infective conditions. So you had to do a thorough investigation. Not only that, any patient who is decompensated requiring hospital admissions, or they develop other complications like encephalopathy or sepsis in particular, they should be tapped for the diagnostic tap to make sure that we understand what is the nature of this ascites. Okay, the important things, as we all know, that we look at when we tap the ascites, is there any SBP? Okay, so that's the definition of the SBP, which is universally used. If you have a neutrophil count, the absolute neutrophil count more than 250 cells per microliter, that is actually an SBP. So once you have a patient with SBP, their mortality rates are significantly higher. They're at risk of developing hepatorenal syndrome and AKI. So, and the mortality rates we talk about is between 3 to 6 months. So it's important, again, another landmark in the patient's history when they develop the SBP. So if you look at the natural progression of these patients with cirrhotic livers, when they progress from compensated to decompensated, when they develop ascites, that's an important landmark. And when this ascites becomes from uncomplicated ascites, it becomes refractory ascites, that's another important landmark. We are markedly reducing their life expectancy. And in that refractory ascites, if they do develop SBP, that significantly reduces the survival. So I think realistically, any patient who develops ascites should be worked up for a liver transplant regardless. Okay, so and also another important point when we actually look for the ascites is not only just the neutrophil count, we also look at the protein levels. If they have the protein levels, that actually indicates if they're at risk of developing SBP. Okay, so you got to look for these for the SBP. You need to make sure that there's no infection, and you also need to make sure that there is no malignancy floating around anywhere. Okay, now why is it important? As I said, even in the uncomplicated ascites, the 2-year mortality rates are almost 50%. So by 2 years, more than 50% of the patients would have died if they had developed this, even the uncomplicated ascites. Now that figure comes down to dramatically to 6-month survival in patients who develop refractory ascites. So it's important that when we see a patient with ascites, we should start getting worked up for transplant. Now, the other problem with this, or the other thing why we need to be proactive in terms of referring these patients for liver transplant, is most of the scoring systems that we use, like the sodium MELD score, the MELD score that we use, do not incorporate the ascites into the equation. So a lot of times these prognostic scores that we use, they underestimate the mortality risk. So they often gets pushed down into the in this transplant waiting list for these patients, which increase their mortality. To counter this, some of the centers have actually started using the MELD exception scores, and along with the patients with HPS and portopulmonary hypertension, even ascites or chronic encephalopathy, these are all MELD exceptional patients, where even if they have a lower MELD scores, if they do develop refractory ascites or uneven ascites, I think they should be listed for a transplant. So I think there have been some modifications which are happening, but still a lot of work is still in progress in terms of properly vetting these patients who should be on the top list when they develop ascites. Okay, so very quickly about a couple of slides about the treatment for the uncomplicated ascites, and then we go to the refractory ascites, which is probably the meat of our talk. So uncomplicated ascites, mild ascites, again, the only treatment which has been very helpful in multiple systemic analysis is basically sodium restricted diet. Okay, so that is the only evidence that we actually has shown that a great beneficial role in terms of the treatment for the ascites, and particularly in uncomplicated ascites, that is certainly that you need to look at as your treatment of choice. Okay, if you do develop grade 2 ascites, in other words, you got moderate ascites, then you, along with the sodium restricted diet, you should also start looking for adding diuretics for these patients. Okay, so you should tell the patients to have no added salt. Okay, often what we say in our clinic is when they prepare the food, to prepare it without no added salt, and then they can keep that dish to the side, and then for the rest of the family they can do a normal a dish with added salt. But patients with uncomplicated with ascites, they should be having no added salt. But it is also important to understand that people who can't tolerate no added salt, we can probably add a little bit of salt, because it's important that nutrition is still maintained. Because if these patients are getting sarcopenic, then you are missing the boat. It's actually more counterproductive, and your risks are much higher of not having food rather than having food with a little bit of salt in it. So I think it's important to address that they maintain the nutrition, at the same time they take low salt diet. Okay. In terms of diuretic choices, the obvious choice is obviously spironolactone antagonists, like the aldosterone antagonists like the spironolactone, which, as I showed initially, if you look at the pathophysiology, it counteracts or reverses the renin-angiotensin system and the aldosterone activation. Therefore, I think without any brainer, the spironolactone or the aldosterone antagonists are the treatment of choice. The usual treatments, which are started at the aldactone at 100 milligrams per day, and we can increase in a stepwise manner in a 2 to 3 day. And although literature says we can go up to 400 milligrams per day, but I think realistically, a lot of us don't go beyond 200 to 300 milligrams. I think that the highest I've used is 300 milligrams per day doses, but I don't think people generally tolerate more than 300. They get a lot of renal impairment, other refractory ascites problems with higher doses. So what we tend to do is we start with aldactone 100, and then we add a loop diuretic like a furosemide or a torsemide at 40 milligrams per day. And then you gradually escalate in a sequential manner. So you increase spironolactone to 200, and then you increase the furosemide from 40 to 80 milligrams, and you see the response. Now, it's important that you understand the response to these treatments. Quite often what we say is patients is refractory treatment because, despite giving maximum doses, they're not responding to it. But what happens is patients are poorly compliant to the medications. And the way you can look at it is every time when the patient comes with ascites who we think they're not responding, we should always check for the urinary sodium and the potassium levels in our clinic. So that tells us whether the patient is compliant and is he taking the medications regularly and is he diuretic responsive. So if the patient is not diuretic, is not taking medications, obviously they will be not leaking out sodium, so they'll be absorbing a lot of sodium. So their urinary sodium will be very low and they won't be losing any weight. Okay, so if the patient is taking diuretics and is not responding or is not responding to treatment, so they won't be reducing weight, but yes, their urinary sodium will be more than 10 micromillimoles per on that assessment. So if you have excess sodium excretion, but they're not losing weight, that means they're diuretic intolerant. If they are responding, then they'll be obviously leaking a lot of sodium, which is what we want to do with these diuretics. Along with that, they'll be also losing weight. So that is how you can actually assess a response to the treatment. And it's very important that you address every time when they come to the clinic on the low sodium diet, along with using the medications regularly. So I think these are two important things that has actually shown good evidence. We need to work on those things. Okay. And in terms of monitoring, I think when you start the patients on diuretics, it's very, very important that we check the renal function very carefully. The reason we do that is these patients have a very fragile hemodynamic systems. The systemic circulation and the perfusions are very poor. You already have a slogging kidney, and on top of that, if you actually give these diuretics, it's going to impair the renal function. So it's very important that you check these patients regularly for the renal impairment. So you monitor them very carefully, and you aim to reduce weight by at least 1 kilogram per day if they're edematous. If they're not having peripheral edema, then up to 0.5 kilograms per day is what we should start looking for. And any hint of any hyponatremia, because as you can see even in the prognostic scoring systems that we use, sodium has been incorporated into the MELD score, what we call a sodium MELD, because that tells us about the hemodynamic status of the patient, how the renal perfusion is happening. So if they develop any hyponatremia or AKI or any worsening encephalopathy, or if they're having incapacitating muscle cramps because of the electrolyte disturbances, you should think of discontinuing the diuretics. And if you have hyperkalemia, obviously you stop the aldactone. If you have hypokalemia, you also stop the furosemide. Okay, sometimes we do use albumin. I'll come to that in further of my slides. Why albumin has somewhat taken center stage lately because of a few studies, which I'll just go through them in a bit. Okay, so if you have a large volume ascites, then yes, of course, you can use the LVP, the large volume paracensis for these patients, of course, in very strict sterile conditions. And every time when you poke, you should make sure that you check for the TCDs and make sure there's no SBP. You can remove up to 5 liters of fluid without having any hemodynamic changes. So you don't have to give any plasma expanders like albumin. But if you are taking out more than 5 liters of fluid, you should always replace them with the plasma expanders because of the circulatory dysfunction that happens after the post paracentesis. Okay, so and make sure that on the day of the LVP, you don't give the diuretics and you start them the next day after checking their blood pressure and stuff, hemodynamics and the pulse. Okay, so the little contraindications for the LVP, obviously, if there is a severe abdominal bowel distension, or if you have severe coagulopathy, if the patient is pregnant, and if they have any puncture site wounds, uncooperative patients, obviously, we won't attempt for LVP. Generally, we do it at the bedside if it's quite obvious large volume ascites, but if it is grade 2 ascites or difficult ascites, loculated, obviously, we had to try and do it ultrasound guided tap. And you should always look for these culprits or the villains. NSAIDs, absolute contraindication patients, but cirrhotic liver, not only it impairs the AKI, but obviously it impairs it causes more decompensation. So you should make sure that you avoid NSAIDs at any cost for these patients. In fact, and as we all know, the choice of painkillers for patients in cirrhotic liver is very limited, which has always been a contention of the bone to use, where we had to use it very religiously for these patients. And you should always be cautious and stop the ACE inhibitors, angiotensin 2 antagonists, and the alpha-1 adrenergic blockers. In fact, yesterday we had one patient who is in these patients who generally we seeing more of NASH-related patients, as I said, NASH-related decompensated. Often these patients are taking antihypertensives, anti-anginal medications. So they've been using lisinopril, ramipril, all these drugs for a while for the liver problems. And when you're actually starting these patients on beta blockers, and if they have ascites and they're at risk of developing AKI, you always have to look for drug interactions and see that you're not double dosing them, and also make sure you stop these medications because obviously blood pressure will be low and they don't often need to take all these other antihypertensives. So also should be very careful in using any nephrotoxic drugs like aminoglycosides, and very cautious in terms of using contrast media. You should be absolutely clear that there is a benefit of doing a contrast study because risk of renal impairment is very high. So in other words, what I'm trying to tell you here is patients with ascites, even if it's uncomplicated ascites, their kidneys are very fragile. We don't mind having a bit of ascites, but we don't want to compromise on the kidney function. That's very important, because once they start having kidney compromise, then they will just go spiraling down, and they significantly have ascites and decompensation, which rapidly progresses. So coming to the refractory ascites, the International Ascitic Club defines refractory ascites as ascites that cannot be mobilized or has early recurrence of which, and even after LVP, which cannot be satisfactorily prevented by medical therapy. So in other words, it fails to the medical therapy, and there's either early recurrence or we cannot budge that ascites. That is what we call as a refractory ascites. Now, to keep it simple, it can be divided into diuretic resistant ascites or diuretic intractable or intolerant ascites. Now, what is diuretic resistant ascites is you have the refractory ascites, which is happening despite the sodium restriction and the maximum amount of diuretic treatment. That is diuretic resistance. So in other words, they're resistant to the diuretic treatment, and that's why they're developing the refractory ascites. Now, intractable or intolerant ascites is patients who can't tolerate the higher doses or even the minimal doses of diuretics because of their complications, side effects. For example, like hyponatremia, or they're having a renal impairment. In these patients, we can't increase the diuretics or give even at adequate doses. Therefore, we're not able to remove the ascites. So that is the diuretic intolerant or intractable ascites. Now, it's important to understand these subtle differences, because your treatment will be can be channelized or based on these kind of definitions. Now, there has been some changes in terms of definition of the AKI, as you know, over the last 2-3 years, and that has reflected in the refractory ascites, the AKI definition in the cirrhotic livers as well. So, who do we call refractory ascites? Is patients who are on intensive diuretic therapy for at least a week and on sodium restricted diet. Despite that, they don't have a response. In other words, they don't lose weight, and their urinary sodium output is less than sodium intake. In other words, they're not able to remove the sodium from the body. Or if they have early recurrence of grade 2 or grade 3 ascites within 4 weeks of initial mobilization, that is also refractory ascites. Or if they develop any of these complications like encephalopathy, renal impairment, hyponatremia, electrolyte disturbances, or incapacitating muscle cramps, which is restricting the use of diuretics. These are the conditions where you actually start looking at the refractory ascites. Okay, so as I said earlier, the median survival of these patients once they develop refractory ascites is hardly 6 months. So it's important that you start evaluating these patients for the liver transplant. And it's very important, as I said, to look for the compliance of these patients for the salt-restricted diet and also the use of the diuretic therapy. Okay, so if you have large refractory ascites with large volume ascites, then LVP plus albumin has been a standard of care, which we've been using for a number of years. I think that still holds good for most of our patients, but there have been some newer additions to the treatments, which we'll discuss in a bit. Along with that, there has been some controversy about the use of the non-steroidal beta blockers in refractory ascites. I got some slides about the use of beta blockers in these patients with refractory ascites, but in general, initially we used to say, non-steroidal beta blockers has been used to so non-selective beta blockers have been used to reduce the portal hypertension, and therefore it reduces the incidence or the occurrence of the ascites. But I think once you start developing refractory ascites, your renal perfusion minimizes, your systemic circulation or hemodynamics start changing significantly. Therefore, any lowering of the blood pressure will affect renal perfusion, causes hypoperfusion, results in renal impairment, which indirectly increases the mortality of these patients with cirrhotic liver. So therefore, I think once you develop refractory ascites, if your mean arterial pressure is less than 65 mmHg, and I think you should definitely stop the non-steroidals. The risks at that point are much significantly higher than the benefits of using the non-steroidal blockers. So you should start looking for these patients of discontinuing the non-steroidal, non-selective beta blockers, which they would have already been on once they develop the cirrhotic livers. So it's important to understand that. Okay. Now the other part of the refractory ascites, which doesn't go without using the describing about, is the renal impairment. It's very important, as I said, the AKI or the renal impairments is important. They go very hand in hand in terms of the cirrhotic livers. So there's been some changes to the definitions of AKI, but once you have a patient with the liver disease, even a mild increase in serum creatinine, you should take that as a significance, because these patients generally are sarcopenic, they have very low muscle mass, and because they have low muscle mass, you expect creatinine to be very low. In fact, the baseline creatinine probably will be around 0.3, 0.2, or even 0.4. So even if it jumps to 0.7, 0.8, even then, although it is less than 1.2, which is the upper limit of the normal, you still have to consider that has an AKI. To account for all these changes, that is the reason why there has been some changes to the definition of AKI, the acute kidney disease, and the CKD. Okay, so first important step is to understand what's the baseline creatinine. Is there an increase even in the mild increase in serum creatinine? So is this patient having CKD, or is it a new onset acute kidney disease, or is it acute kidney injury, or is it an overlap acute and chronic kidney disease? So it's important to understand what is the CKD is. If you have less than GFR less than 60 mils per minute on the body square for at least for more than 3 months, then you call it as a CKD. Okay, so this is a newer definition where if there is of AKI, if there is an increase of serum creatinine of more than 0.3 from the baseline within 48 hours, or if there is a more than 50% increase from the baseline within the 3 months. So for example, as I said earlier, if the patient's baseline creatinine is 0.3, if it jumped to 0.6 then that is an AKI. Although it is still in the less than 1.2, that is still in AKI. So it's important that the newer definition incorporates the baseline creatinine, and it's important to understand this baseline creatinine in these patients. So AKI is when you have an increase in serum creatinine of more than 50% within 7 days, or there's a jump of serum creatinine of more than 0.3 within the 2 days, that is AKI. AKD is similar to what we see above, but reduced GFR of less than 60 mils with the kidney damage less than 3 months, or if there's an increase in serum creatinine more than 50% in 3 months. If the same thing happens of more than 3 months, that is a CKD. So it's important to understand what the baseline creatinine is. If you have the baseline creatinine over the last 3 months, then you take the value closest to the one, you take that as a greater than one value within the previous month, which is the value closest to the admission, is what you take as the baseline creatinine. If you don't have that, then you take as the serum creatinine admission as a baseline. And the definition of AKI is, as I said earlier, it's important to understand this because a lot of the slides and a lot of the studies which have been used, and a lot of the literature all consider this as a baseline or the gold standard. So increase in serum creatinine more than 0.3 within 48 hours, or increase in serum creatinine of more than 50% within the prior 7 days. If you take this into equation, most of the patients who actually come to the hospital decompensated will have AKI of certain level, whether it's stage 1, stage 2, stage 3, but most of them do have AKI. So if the increase is more than 0.3, but less than or increase of more than 1.5 folds to 2-fold increase, then that is stage 1. More than 2 to 3-fold is stage 2, and more than 3-fold, or if you have serum creatinine more than 4, is stage 3 acute kidney injury. And you start looking at the progression. Are they having any response to treatment, or is there no response to treatment? So it's important to understand the baseline creatinine, what is it, and how much has it risen to when they're admitted, and how they're responding to the treatment. Do they fall into stage 1, stage 2, stage 3? Okay. Now it's important to understand this because your treatments will be titrated or targeted based on these levels. Okay. So if you have stage 1 AKI, then you actually obviously remove all the culprits like nephrotoxic drugs, all the vasodilators, and the NSAIDs, as we discussed. You stop the diuretics or withdraw the diuretics, you stop the beta blockers, you give plasma volume. In other words, you are looking at hypoperfusion related, so remove all the nephrotoxic culprits and you start them on the plasma volume expansion. If there's a resolution, then you continue with the close follow-up. If there's a persistent, then you treat persistence of this, then you treat on a case-to-case basis, but most often we end up giving plasma volume expanders along with the vasoconstrictors, like the telepressin. Okay, so if there's a progression of this stage 1A, or if they are more than stage 1A, in other words, stage 2, stage 3, or they have significant AKI, then obviously along with what we do in stage 1A, you withdraw the diuretics, you do plasma volume expansion with albumin. If there is no response, then you start looking at whether is it an HRS, AKI, or what we call ACI-HRS. If it is ACI-HRS, then along with the albumin, you start giving the vasoconstrictors. Now, often these patients over here, they can also end up having ATNs. As you know, HRS is a diagnosis of exclusion. Most of these patients with the CKD who develop ascites and refractory ascites, and they develop renal impairment. Most of them, they do have pre-renal causes and ATN, okay? But also you need to exclude any post-obstructive causes as well. So one of the biomarkers which has come up lately, which is still in the analysis or the evaluation, is the NGAL, urinary NGAL. If it is ATN related or acute tubular necrosis related renal impairment, you would expect to have a epithelial CAS and the white cell CAS, and also high levels of urinary NGAL. Whereas in HRS patients, you would not expect to have high levels of NGAL. That's how we can differentiate between ATN and the HRS. Of course, it's important to understand that because the treatments of both of them do vary in certain ways. Okay, so the newer definitions of the ACI-HRS, which was previously the HRS, is incorporating the same the ICA-AKI criteria AKI definition, which I showed you earlier, increase in the kidney renal creatinine impairment, as I discussed earlier. So the prerequisite for HRS is obviously as before. You should have cirrhosis with ascites. That's very important. And they are not responding to plasma volume expanders with albumin at least on 2 consecutive days. And there is no evidence of any shock, particularly septic shock for these patients. You removed all the culprits, and there is no structural damage to the kidney, and there is also no post-renal causes. Okay, so when you satisfy all these criteria and they still have AKI, then that you call that as a HRS. Now, previously type 1 HRS, and now we call it as a ACI HRS, and type 2 HRS, which is a chronic development of the HRS, we call it as a NACI HRS or NAKI HRS. Okay, so as I said earlier, you should have prerequisite cirrhotic liver and ascites. They should fit the criteria for the AKI using the International Ascitic Club and the AKI criteria. They should not be responding to the volume expanders. They should not be having shock, no nephrotoxic drugs or any contrast medium being given, and absence of any structural damage to kidney, like there's no proteinuria, there's no microhematuria, and they should have normal looking kidneys, so certainly no post-obstructive causes as well. So in these patients, once you actually diagnose them as having HRS, so you start adding, along with plasma volume expanders, you start giving terlipressin for these patients. And there's good enough evidence that terlipressin in these kind of situations do improve the outcomes, although most of the studies have not shown any improvement in the long-term survival, but certainly in the improvement in the AKI, there's definitely been a good improvement in these patients. So you give, along with terlipressin, the albumin expansions. Okay, but as I said, I keep saying the same thing again and again. So once they develop any ascites and further complications, liver transplant is the only therapeutic option, or the definitive therapeutic option they have. Yes, renal replacement therapies like the hemodialysis, which we continue to use if they don't respond to the above treatments. Now, the other important point which I want to mention here is in ascites. Of course, I'm not going to mention about tips in the LVP in detail, because that's not the remit of the talk, and that's a topic for other day discussion. But patients who are having large volume ascites with well-preserved, reasonably well-preserved liver function, MEL score is less than 15, I think you should start also looking for tips. But once they develop HRS AKI, tips is an absolute contraindication, because it's going to impair the renal function, and the risks or progression or mortality increases. There's good enough evidence for that. So tips should be used only in patients who having lower MEL scores, good muscle mass, not sarcopenic, no renal impairment, and they're having refractory ascites. So this meta-analysis, which showed that yes, terlipressin, people respond to terlipressin compared to the placebo group. But if you look at the long-term survival, in fact, even 3-month survival, there has been no significant statistical difference. But in terms of treatment response, yes, terlipressin does have a better role compared to a placebo group of studies. Now, this graph shows that what is more beneficial, whether you give it as a continuous infusion or as a bolus doses. So in terms of efficacy-wise, there's a slight efficacy if you actually increase efficacy if you give it as an infusion, and the mean effective dose is adequately maintained during infusion rather compared to the bolus dose. But what has really has shown some benefit is a better tolerance or the less side effects in these patients if you use continuous infusion compared to the bolus doses of the terlipressin. Okay, so if you don't have terlipressin, or it's been obviously terlipressin is quite expensive drug. So in these patients, the other alternative, the vasoconstrictor, a potent vasoconstrictor is the noradrenaline, and I think there are enough studies to say that noradrenaline is a better alternative to the terlipressin in these patients. And as you can see here, there's no statistical difference between the terlipressin albumin group compared to the noradrenaline. There are some studies which have been used comparing terlipressin plus albumin versus midodrine plus octreotide and albumin. Mind you, these are very small studies of only 30 and 45 patients. And in terms of reversal of the type 1 HRS, so far terlipressin albumin outscores on the other drugs. But having said that, we should understand that these are a small group of patients. I'll just skip this slide in the interest of the time. We have already covered this part in the previous slides. Now, the other important change that has happened is, which has taken a hot seat lately, is the albumin. Albumin has been used for a number of years, but lately it has taken a center stage because of the newer trials, which has shown that not only albumin, which acts as a volume expansion as an oncotic because of oncotic properties, but it also has a lot of other non-oncotic properties like anti-inflammatory properties, anti-thrombotic properties. It stabilizes the endothelium. It has good binding capacity to the proteins, and it also has a scavenging effect. Because of this results, because of these properties, not only it shows that increase in volume expansion, but also it helps in improving the mortality and reducing all these complications which we do develop in cirrhotic livers. And therefore, I think the newer definition or newer kind of concept which has been said is that the albumin is the newer disease modifying agent in the cirrhosis. So it reduces along with increasing the oncotic pressure or as a plasma volume expander, it also reduced the pro-inflammatory cells, as I mentioned earlier, the endothelial stabilization, the reduction in lipopolysaccharide LPS activation. Therefore, it helps in reducing the splanchnic vasodilatation. It improves the circulatory dysfunction, cardiac output improves, renal impairment is reduced, along with the adrenal dysfunction and the encephalopathy. So I think there are a lot of important roles of albumin, not only just as an oncotic supplement, but also as other non-oncotic properties. Now, this study, which was published in Lancet 2018, has actually changed a lot of the practice lately. The ANSWER trial, which was a multicentric trial, which was conducted in 33 centers in Italy, which is an outpatient basis study, which was done in a stable cirrhotic patients who are on diuretics, who are using fairly good doses of diuretics, aldosterone of 200 or more than that, and furosemide of more than 25 milligrams. These are child B cirrhotic patients, majority of them, and in them they conducted a randomized double-blinded multicentric trial where they used albumin in one arm, the other arm was a placebo-controlled trial. So first 2 weeks, they're given twice weekly albumin of 40 grams. And then after that, subsequently, they used weekly once albumin for 18 months. And the primary endpoint was looking at the 18-month mortality in these patients. Now, this study clearly answered that there has been a significant improvement in the survival rates of these patients who have compensated cirrhosis, decompensated cirrhosis with stable ascites, child B cirrhosis. These patients, if you actually start giving albumin in earlier days of the treatment, it has shown significant benefit in terms of survival rates. And also the first time of the paracensis has also been delayed. So in other words, you're able to get a more stable disease and minimize the disease progression. Not only that, it also showed that there has been a reduction in the liver-related deaths in patients who were taking the human albumin and the standard medical therapy compared to only the standard medical therapy. And also the time to refractory ascites is also increased in patients who are getting albumin along with the standard medical therapy compared to the placebo. So the study concluded that it improved the 18-month survival rates. It's easy to give the albumin it can be done as an outpatient settings. It improves the quality of life of these patients, reduces the number of hospitalizations. And in the Italian group, they said it's cost effective, but that's subjective to each individual country, I guess. But in countries like India, where albumin is quite expensive, it's still, I'm not sure whether it will be cost effective in the long run for these patients. But the study concluded that albumin is a very good disease modifying drug and very helpful in improving the mortality rates of these patients. Subsequent to this, there are other trials which have showed that, which contradicted to what the ANSWER trial showed. This trial, the MATCH trial, showed that there has been, in fact, no statistical difference in terms of mortality comparing albumin with the placebo group of patients. This is a study which was presented in the EASL meeting just concluded in October this year, 2020, which is called ATTIRE study, which is a UK multicentric trial, which looked at the albumin versus standard care in these patients. And as you can see here, there has been no significant difference in the 3 months mortality. In fact, patients who were getting albumin had more increased adverse events, particularly in child C-cirrhotic patients, having increased heart failure and fluid overload conditions requiring more ICU cares. And not only that, there has been a significant additional cost of £573 for these compared to the standard medical care. So what this trial concluded that, yes, albumin is a good disease-modifying drug, but I think that should be used with caution, and the jury is still out, I think, in terms of whether we should be using albumin in long run or not. This is another study which again was a negative study in showing in terms of using albumin alone. So they conducted this as a double placebo trial with biweekly albumin and midodrine, which has not shown any difference in terms of renal improvement, hyponatremia, bacterial infections, encephalopathy, or GI bleeding. So it has not shown any overall benefit in some of the studies. Okay, so I'll quickly skip these slides. I think I already covered this point. In the interest of the time, I'll skip this. I think it's just basically telling us that using beta blockers in refractory ascites reduces the survival rate. So we should be very cautious in terms of using beta blockers in patients with refractory ascites. So as I said earlier, if you have refractory ascites and if you're systolic and NSBP, as long as you have the mean arterial pressure above 65, then yes, you can use non-selective beta blockers, but you should be very cautious and you should be always looking for these patients where we should actually start discontinuing this, because the risks of continuing will be much higher than the benefits. Okay, the midodrine is kind of a newer kid in the block for the cirrhotic group for us as a hepatologist and as a gastroenterologist. But really, midodrine has been there in the market for nearly 30, 35, or even 45 years, to be honest. This was initially used in patients who were having orthostatic hypotension, and which has showed real benefits in terms of improving the blood pressure and the renal perfusion. So midodrine is basically an alpha-1 agonist, which effectively reduces the splanchnic blood flow, increases systemic circulation, and because it increases systemic circulation, it increases renal perfusion. As it increases renal perfusion, your renal impairment is improved. Okay, so that's how it actually works as a potent systemic vasodilator. Okay, so midodrine is usually used. It has got a very short half-life. I think I got a slide. Yeah. I think the slide probably got jumbled. So it has got a very short half-life. We're talking about only 30 minutes to an hour. So that's the reason why we had to give it in 3 to 4 doses. And it's predominantly metabolized in liver. And this is the active metabolite. The midodrine, and it has got good bioavailability and is excreted through the renal secretion. Okay, so this is the active molecule. It works in the alpha-1 receptor. It increases the vascular tone and the blood pressure. Therefore, it causes vasoconstriction, and it improves the systemic circulation. Therefore, it improves the renal function, and therefore it improves the ascites by increasing sodium and water excretion. So this is the mechanism of action of the midodrine. It's generally given at start with 5 milligrams 3 times a day, and then based on the blood pressure and the MAP, we start increasing doses. The other advantage of using midodrine in these patients with cirrhotic patients is often they have very low blood pressure. So because of that, we tend not to, or they get very intolerant to diuretics very quickly. So therefore, I think this certainly has a role in those patients where you're struggling to give diuretics because of low blood pressure, or if they have hyponatremia or patients with HRS. I think these are the patients where midodrine certainly has a better usage in these patients. Because I think that logically, it's quite simple that it improves renal perfusion. Therefore, it causes improved renal excretion, reduce ascites, which indirectly has improved survival rates. Okay, so there are some side effects and contraindications to the midodrine. So people with supine hypertension, if they have any itching and if they have any frequent urination problems or rashes, we should be very cautious, and these are the side effects. And there are also other side effects or contraindications, like if you have any organic heart disease, urinary retention, pheochromocytoma, thyrotoxicosis, we should be avoiding the midodrine. And a word of caution is when you give midodrine, you should make sure that you give this drug at least 3 to 4 hours before you go to bed, because there's increased risk of supine hypertension, and there has been heart failure and other complications developed because of these conditions. So you should make sure that you give the midodrine at least 3 to 4 hours before going to the bed. Okay, so along with this, midodrine has also been used, as I said, the first actually it was used in orthostatic hypotension. I think I got probably another 2-3 slides just talking about midodrine versus albumin in these patients. This is an Indian study which got published in the American Journal of Gastroenterology, and also another study which was published in Journal of Hepatology, both from Dr. Viren Singh group. And they looked at, it's a very small study. We're talking about 20 patients in each group. They looked at midodrine versus standard medical therapy, and the primary endpoints was looking at the 3-month survival rates in these patients, and clearly that has shown that the initial survival rates, in fact I think that it was 6-month survival as I looked at, was better with midodrine compared to the standard medical therapy. But having said that, in the long run, or the 2-3 years group time, there has been no statistical difference. Now they also looked at the plasma renin ratios pre and post of giving the standard medical therapy versus midodrine. So in the first 20 patients, as you can see, who have been on midodrine, there has been a significant reduction in the renin, plasma renin activity, which is an indirect marker or surrogate marker to say that there has been an improvement in the renal perfusion. Similarly, the aldosterone, the plasma aldosterone levels have reduced significantly in patients who are taking midodrine compared to the placebo, the standard medical therapy. So what they concluded is that if you add midodrine to the standard medical therapy, it improves the hemodynamics of these patients without any renal or hepatic dysfunction. However, as I said, this group is, the study was done only in 40 cirrhotic patients. So still we need a lot of studies in this regard. So I think I already covered this point. In the interest of time, I'm going to move further. There's another interesting study that looked at rifaximin plus midodrine. Again, it's a very small study. We're talking about 45 patients in each group. And again, that showed that there has been some improvement in the survival rates, patients who were taking midodrine and the rifaximin compared to the standard medical therapy. Okay. And another interesting study is they looked at comparison between midodrine and clonidine versus standard medical therapy. And in this study, what they concluded is midodrine and clonidine improves the systemic hemodynamics, as I showed earlier, with the improvement in the renin activity and the plasma and the aldosterone activity. However, clonidine has shown more side effects, and hence clonidine has not been further followed up in further studies. But again, as I said, these are very small studies. We're talking about 15 patients in each group. Okay, so this is about midodrine, which is a neokid in the block who certainly has got role in the cirrhotic patients with ascites armamentarium, but we should be using that with word of caution, and we should know which patients to select carefully. So in summary, so ascites is an important landmark in the natural history of the CLD patients, as I said. And it's important that once patient develop ascites, they should be referred to the gastroenterologist and to the hepatologist for the further definitive therapy. And the only real definitive therapy for these patients with ascites is liver transplant, as I mentioned. And it's important to understand to differentiate between uncomplicated ascites and refractory ascites, and also how to manage the refractory ascites. Midodrine is a new kid in the block, which certainly has got role. And we discussed about their mechanism of action, and they go hand in hand with the diuretics to a certain extent, but you got to be careful in terms of measuring the blood pressure, making sure that they're within that ballpark figure of above 65 MAP, and then less than 85 MAP. So you should titrate the MAPs very carefully. You should be regularly checking for the urinary sodium excretion levels and also seeing the response of the midodrine. So thank you very much for the patient listening. I'm sorry, I think I've taken a lot more time. You guys still there?
Everybody is there. Yeah.
Okay.
I just put myself as mute. It was very interesting talk, Naveen. Very exhaustive. Everything under the sun is covered for ascites. It's a good review for us, for most of us. And one question from the audience. Actually, it was put sometime back. Let me check it. the query from, many are there now. Okay, so one question is, what they put was, just, can midodrine and diuretics be combined in patients with refractory ascites who are no longer diuretic intolerant or resistant, but still require repeat LVPs? I didn't understand the question properly, but what I understand is somebody who's requiring repeat LVPs, and though initially it's labeled as refractory ascites, maybe diuretics are working in between. So the point is, can we combine midodrine and diuretic? Just to say, that's a good idea. You should look at the map for that. Yeah.
I think, absolutely. As we discussed earlier, I think important is to understand the concept here. To understand is you need to make sure that you're not compromising renal function. You make sure that you have adequate renal perfusion, and the important surrogate marker for this is to look at your MAP levels. So if your MAP is above 65, that means your perfusion to the kidneys is adequate. In that case, you can actually add a combined diuretic and midodrine in these patients. I think your question says that for no longer intolerant, diuretic intolerance. In other words, if they're responding to diuretics, I think the first choice would be to start with diuretics. Okay, you would only consider adding these midodrines in patients we think they're intolerant to the ascites, intolerant to the diuretics, and they are dropping their MAP, they're reducing their hyperperfusion. In those kind of patients, adding midodrine will increase the MAP. Okay, so when it increases the MAP, it increases renal perfusion. Therefore, it helps in improving the renal impairment. So, in other words, if they are if they are no longer diuretic intolerant, which means they are diuretic responsive, then you start with diuretics. And then when they become into AKI, then you start adding midodrine into these patients.
Okay, that's an interesting thing. I think I agree with that. One question from Dr. Ajit. Do decompensated cirrhosis patients tend to suffer from ascites? I think decompensation indicates ascites is a part of decompensation. Possibly, I think that's what he was trying to say. And another query is, when you also agree that we need to give some albumin. That's what he said. Beyond 5 liters, if somebody wants to remove more than 5 liters of ascites, you need to give some volume expander, right? So the question is, when you calculate 8 grams per liter of acidic fluid to be removed, that calculation should start from the first mill or after 5 liters. That means 5 liters is base. So if you want anything more, if you want to remove, then calculate as per the calculation 8 grams per liter and give the albumin, or for the whole fluid you calculate.
I think what the guideline says is up to 5, as you said, up to 5 liters, we don't need to worry about the albumin. Yes. But after 5 liters, for every 2 liters that you drain, you add 1 bottle of 20% albumin. So you don't need to calculate from first liter to the 5 liters. It's actually after the 5 liters that you actually. Yeah. So I think often what we tend to do in our clinic is we err on a bit of a caution. We actually start albumin as soon as we remove 5 liters. We start adding more, albumin IV. But I think we should be careful, to be honest, in terms of using religiously, the albumin, because of course you're maintaining hemodynamics, but at the same time you don't want to increase the oncotic pressure in these patients, which will increase the renal, heart failure and other complications from it.
Agreed. So, but I, for one, I always calculate for the whole fluid which I remove. So this is something which I learned today. So the calculation should start after the 5 liters of acidic fluid removal. Other one is how to manage hyponatremia in patients with refractory ascites.
Yeah. As I said, I keep saying, I mean that I didn't deliberately cover that bit because hyponatremia is another big discussion, really. So that's why I didn't cover in my slides. But see, I keep saying this again. I'm sorry to keep saying this again and again. Once the patient develops ascites, this patient should be referred for liver transplant. We should try not to get these patients to the hyponatremia stage, because once they start developing hyponatremia, as I said, it's another indirect marker to say that they have significant renal impairment. Their MEL scores will be very high. Even with the transplants, the outcomes will be, if you delay the transplant for these patients, the outcomes will be very poor. And we're looking at a very poor survival rates without transplants for these patients. So we're not doing any justice by delaying these patients when they develop ascites. Now, if you do develop hyponatremia, generally it is because of diuretic related. So first thing you do is you stop the diuretics for these patients, and you remove the culprits. As you assess for any patients with hyponatremia, you should look for, is it hyponatremia, hypovolemia, or is it hyponatremia hypervolemic, or is it hypervolemic hyponatremia? So you should start looking for the reasons for the hyponatremia. We go back to the textbooks for this, but we got to do this in that way. And you remove the culprits to start with, and you start giving plasma volume expanders for these patients. I'm very cautious about using tolvaptan because we've seen dreadful results with tolvaptan. There's patients decompensate very badly with tolvaptan. And of course, the sodium levels go up quite significantly, very rapidly, but you cause a lot of diuresis, your renal impairment starts getting worse. You're already, you're clogging liver and your kidneys, you're giving tolvaptan and you're actually making it worse. And in fact, in Birmingham, we never used to give tolvaptan for these patients. If we do have to use it, the only patients where we used to use tolvaptan is patients who we think the liver transplant is like a bridging for liver transplant, where we know the liver transplant is already ready for this patient. You just want to increase the sodium so that you minimize the risk of the CPN post transplant or during transplant. So in those patients, to quickly increase the sodium, we give tolvaptan, and we always used to give it in an ICU setting where we carefully monitor these patients. So please do not use tolvaptan for patients who got cirrhotic livers. They decompensate very badly. And a lot of studies which have actually shown negative results in using tolvaptan, and it has not been recommended by any of the guidelines.
So, but in child C, tolvaptan is definitely contraindicated. So the one you are trying to tell us in Birmingham is, in child C, while waiting for transplant, you give tolvaptan. That was a little unusual, but maybe on control situations.
Control situations only. We see if we think that, say, for example, the patient's sodium is 121 and he's got a transplant end up in 3-4 days, and we don't want to miss that boat for that patient where there'll be. So most of the transplants in UK are cadaver based, isn't it? So we don't want to miss that opportunity. So we try to give the tolvaptan to those patients to increase the sodium. But otherwise, tolvaptan should not be used in patients who got ascites.
Particularly child C, particularly.
Yeah.
Yes. Yeah. And there's an interesting question again. Can we replace albumin with midodrine? Definitely not.
No, I think standard of care still will be albumin. As I showed you in some of the slides, there have been some comparative studies with albumin plus midodrine versus albumin, but no studies have been done head-to-head between albumin and midodrine. Okay, so albumin still stays in the pipeline very much in terms of treatment for the cirrhotic patients with ascites.
Yeah. The last question is, can LVP be done with adequate albumin infusion in patients with refractory ascites and creatinine more than 1.5 milligrams per deciliter? That means somebody has a high creatinine, more than normal, with refractory ascites. So should we give albumin while removing the fluid?
Yeah, I think that's a standard of care, isn't it? So anybody who's got, we're taking LVP or taking more than 5 liters, then you start giving albumin to them.
Yes.
The standard care.
So
as I said, the ANSWER trial, which was done in the outpatient setting, which has shown a significant improvement in the survival rates, 18-month survival rates. But we have to be using that with caution because I showed you the other study, the ATTIRE study from UK, which did not show any improvement. In fact, there's no statistical difference in terms of 3 months mortality, but also increase the side effects and the cost to the patient. So we had to still use that with a caution. We need to choose the patients who to use, who not to use albumin.
Okay, that's good. But looks like albumin is going to stay in our environment for most of the patients. Yeah. I think one last question. I think I know we're running late, so still because there's no other agenda, so I continued the discussion. So the last question from my side is, like tolvaptans, when they introduced
cirrhosis में ascites में उसके बाद फिर
I think somebody wants to ask a question, I think. Yeah. Okay. The question is, about 10 years ago, we were talking about tolvaptans and there's going to be a stay in the market. But then, as you see, not much usage nowadays for the tolvaptans. About midodrine, Naveen, you think there's going to be a future or it's going to be like another tolvaptan? What's your take on that?
I don't think it will be like another tolvaptan, to be honest, because logically there are a lot of benefits from midodrine in terms of increasing the. See, a lot of these patients with cirrhotic ascitic patients, they run very low MAP. Okay, so the systolic blood pressures will be very low, and in those patients, when you're giving diuretics, it will even reduce it further. Okay, so. And we know that if we increase renal perfusion, their ascites improves, the mortality figures improve, their survival rates are better. So you got a drug which increases the systemic blood pressure, increases renal perfusion, and it goes hand in hand in terms of diuretics and in terms of increasing the MAP. Therefore, logically, yes, it has got role, but as I said earlier, we still need a lot of studies. I think we only had very little studies. We're talking about, in the largest study which was done is about 120 patients, so we don't have much data in terms of the long-term usage, long-term survival rates. We don't have that much of data. So I think still a lot of studies needs to be done in terms of midodrine. But I think looking at the logical aspects of it, yes, I think it's certainly one of the drugs which will certainly stay in the market.
Okay, so then the last question is, a comment from you. So in general people, like some of the physicians who are treating ascites and most of the gastroenterologists, every gastroenterologist who is treating the ascites, midodrine, again, just summarize for us in one sentence where I have to use midodrine. Don't confuse with a lot of tongue twisters from your side. You said hypovolemic, hyponatremic, all that stuff. So just with which condition I should use the midodrine?
So HRS patients, hyponatremic patients, and also in patients who are having diuretic intolerant, particularly because of low blood pressures. So these are the patients where I think you would definitely have a role in midodrine. But I keep saying it is not so simple as we can give it in one shot. There are still a lot of ifs and buts in terms of using midodrine, and you have to be very careful, and you need to know how to use a drug too.
Yes. So thanks a lot, Naveen. It was a fantastic session, though it would take a lot of time, but it was very good. So thank you very much. And with this, I think we can close this both the sessions. The first one, Naveen just now we finished about the midodrine and the ascites. The other one is that Somsekhar. The take-home point from Somsekhar is the indomethacin is going to be useful in preventing post-ERCP pancreatitis. Just that. In other conditions, it is not there. There's no need for using indomethacin in other case of pancreatitis, other case of acute pancreatitis. Still, there's no data about that, so we cannot recommend anything in that direction. So with this, I think we can close the session for today. Thank you very much. I thank the Hetero group for organizing this talk. I think you are there.
Yes, sir. In fact, I should thank you, sir, for a very robust and dynamic meet we had. Really, during the launch of Indomethacin and the launch of midodrine, we have gone through a lot of medical science learnings. But today, the way I saw the deliberations done by Dr. Somsekhar sir and Dr. Naveen sir, and I was splendid with absolutely a lot of, it was like a thesis, like a study, whatever. And Nagarjuna sir, really great the way you have made the show go on, and everything was glued to the screen. Really, we are very thankful to you for today's evening. I really thank you all for the being. I thank you. I thank the audience who have logged in today to go through the lecture and all these things. And many doctors have asked to send the videos after the program is over. Actually, it was a really great, sir. Thank you very, very much for being on air for this very special webinar today. Thank you.